Yeah, thank you, Tushar sir. Good evening, dear friends. I hope my slide is visible.
Yes, it's visible.
At the outset, let me thank the organizing committee of the Sunday webinars of Endocrine Society for giving me this opportunity. So I will be discussing about assessment of osteoporosis beyond DEXA, like what are the other methods that we can use in the assessment of osteoporosis. DEXA, it has been the most commonly used technique for measuring bone mineral density. It's available for almost 2 decades now, and we have been routinely using it. It measures the 2-dimensional bone density. That means it calculates the areal bone density it is calculating. The volumetric bone density it doesn't calculate. So the basic purpose of DEXA is to identify individuals at risk of developing future fractures so that preventive strategies can be employed. Changes in BMD over time may be of value in determining the response to therapy also. So it is used for diagnosis as well as for treatment monitoring. So it's a cornerstone for diagnosis of osteoporosis. If you see most of the guidelines, the diagnosis of osteoporosis based on BMD assessed by DEXA. And most of the fracture prediction studies, treatment monitoring, everything they have used BMD. So it's the most extensively studied in tool in various intervention studies. But still, using DEXA alone, that is BMD assessment by DEXA alone, would be a less optimal way as an interventional threshold for several reasons. What are the limitations of DEXA? We will just see. One is a large number of factors are there which we should recognize. The other, the conditions like osteoarthrosis, osteoarthritis of the spine or hip, they can falsely increase the BMD value. But the t-value, the t-score might come up as a high value, but doesn't necessarily mean that the skeletal strength is better. Also, the presence of osteomalacia, a complication of poor nutrition in the elderly, it can underestimate the total bone metrics because of decreased mineralization of bone. And on top of this, so these are like disease factors. On top of these, other technical factors are also there, like even the position of the patient. If the patient is not correctly positioned, that itself, a mild degree of rotation itself can lead on to erroneous calculation of the t-score or the BMD score by DEXA, as well as other factors like recent vertebral fracture itself can increase the t-score, can increase the BMD, calcium tablets, renal stones, osteophytes, recent barium study. Several factors can lead on to erroneous calculation by DEXA as far as the BMD is concerned. So those were the technical things. And coming to other things which are associated with the fracture itself, the fracture risk varies markedly in different countries. So if you see the fracture risk data from several countries, you can see that it varies from country to country. But the t-score hardly varies from country to country. There's only a very minimal difference in the t-score. So the t-score, the significance of any given t-score to fracture risk will depend on the age also of the patient and presence of other clinical risk factors also. The score alone is not enough. We have to take into account several other factors which will be important in assessing the fracture risk of the patient. And the t-score, as the age increases, a value say 2.5 minus 2.5 standard deviation becomes less significant because naturally the t-scores decrease with age. So for somebody say around 80 years of age, why minus 2.5 doesn't necessarily mean that there is high risk. But for somebody of say 50 or 55 years of age, minus 2.5 would be a value which indicates high risk. In contrast, a prior fragility fracture is a high significant factor at all age. At any age, if there's a history of prior fragility fracture, that itself is a significant risk factor. And majority of the fragility fracture which occurs in patient, actually, if you look at the BMD of those patients, their BMD actually falls in the osteopenic range, that is between -1 and -2.5. They need not have, all the patients with fractures need not have values less than -2.5. So there are several non-skeletal factors also which impact the fracture risk. So BMD is only one of the determinants. It's not the only determinant. It is only one of the determinant of the bone strength. But despite these limitations, DEXA, using DEXA and the corresponding T-score from the vertebra and hip have been shown to be a key component and tool to identify patients at increased fragility, fracture risk. And most importantly, in India, we have less resources available. The number of available DEXA scanners in India is very limited, with only around 0.26 scanners for 1 million of the population. And this necessitates a judicious use of the DEXA facilities. So we have looked at DEXA, but during the discussion, I have told that it is not just the bone mineral density score that is important. There are several risk factors also. So these are some of the risk factors which have been studied in various population-based studies. So on the top, the first graph, you can see that in which they looked at the 10-year probability of fracture in patients of different ages and the T-score they have given. So minus 1.5, minus 2.5, and a patient with his prior fracture history. So you can see that naturally with age, minus 2.5 has a higher risk. But once the age reaches say around 75, 80, you can see that the difference is not that much. But for a patient with prior fracture, actually the risk of fracture still increases steadily, even after 75, 80 years of age. So on top of the T-score, age is much more an important fracture, as well as the history of prior fracture is also an important factor. On the second graph, you can see that for the same T-score, that is -3, you can see that as the age increases steadily and dramatically, the fracture risk also increases. And the third graph shows the incidence of fracture in these are basically European studies. So from various European studies, you can see that the fracture probability for women aged 65 years with a T-score of -2.5, it varies dramatically between various countries. So these are the various European countries which have been studied. And in certain countries, there's much higher incidence. In other countries, the incidence is not that much high. So geographical variation also can be there. On the bottom part, there is one graph which shows various factors which have been studied. And these are some of the factors which have been incorporated into the FRAX score. So a prior fracture history, a recent spine fracture, family history, glucocorticoid usage, as well as the dosage of glucocorticoid. The dosage of glucocorticoid is high, the risk naturally increases. The BMD score. Based on this, you can see that for the same age itself, depending on the number of factors, the risk of the patient varies significantly. Depending on the number of factors, for a 70-year-old female, the risk can vary from 17 to 30, depending on the number of factors. As well as the same case for a 60-year-old woman, the risk can vary from 10 to 15, depending on the presence of various risk factors. And the last graph shows the incidence of fracture in various age groups in patients with a prior history of fracture. So these ladies had a previous history of fracture and they were studied, and you can see that it again is different in different countries. These are the main countries which have been studied. This is also a European study, and you can see that in a younger age, actually, the difference is much more marked. Like, for example, in this study, the UK had the higher incidence as opposed to Spain, which had the lower incidence in younger age groups. But say in 80 and 85, those age groups, the difference is not that much marked. So there are a large number of factors, not just the T-score, which is important, a large number of other factors like age, previous history of fracture, family history of fracture, glucocorticoid usage, the geographical location, the country, all these are important factors as far as the fracture risk is concerned. And these are the main risk factors which are associated with the fracture risk. Most of the things we already discussed. In addition to that, secondary causes like rheumatoid arthritis, untreated hypogonadism, inflammatory bowel disease, type 1 and type 2 diabetes, prolonged immobility, all these can be risk factors. So all these we need to take into account when we are assessing the fracture risk of a patient. Just T-score alone will not be enough in most of the patients. So what are the other methods for assessing osteoporosis and or fracture risk? There are other radiological assessment methods also. Then there are bone turnover markers. Then there are tools to assess the fracture risk. Other radiological assessments include vertebral fracture assessment. Then we have quantitative CT, peripheral quantitative CT, quantitative ultrasound. All these other measures are available. Vertebral fracture assessment because vertebral fractures can be asymptomatic, but when we detect that, that is one of the strongest risk factors for subsequent fracture at the spine as well as other non-vertebral sites. So vertebral fracture assessment can be considered in high-risk individuals using either the lateral lumbar or thoracic spine X-rays, or in the same DEXA imaging, we can look at the lateral spine view, and then we can see if there is any fracture. So recommendation-wise, vertebral fracture assessment should be considered in postmenopausal women if there is a history loss of more than 4 centimeter, if there is kyphosis, if there is recent or current long-term oral glucocorticoid therapy, if the BMD T-score is less than -2.5, or even if there is a history of non-vertebral fracture. This recommendation, it has come up in the ISBMR guidelines also, that we can go for a vertebral fracture assessment if there is risk factors like this in the postmenopausal woman. The advantage of vertebral fracture assessment is that one is it involves less radiation, and it is less expensive than a conventional X-ray examination, and almost performs comparably to the traditional radiographs. And vertebral fractures, as I already discussed, it occurs in several patients who actually fall into the osteopenic category. They may not be having the T-score, which is in the osteoporotic range. Then there are quantitative CT and quantitative ultrasound. They are more of a research purpose. We don't use it in clinical practice much often. Quantitative CT involves a different CT machine itself. Some changes in the machine is required. And then it involves much more radiation exposure. So not that much routinely used unless in a research study or in such a setting it is more done. Quantitative ultrasound can assess the calcaneal bone mineral density. It has been found to have some prediction value in fractures in postmenopausal women. But again, not much of long-term studies are available. So it's not recommended for screening or initial decision-making regarding treatment of osteoporosis. One other important aspect which is there are the bone turnover markers. They are dynamic parameters that reflect the short-term acute changes in bone remodeling status that are not measured by BMD. So they don't have a role in the diagnosis of osteoporosis. They are mainly used in the follow-up of patients who are on anti-osteoporotic treatments. So they reflect the therapeutic response much faster than the changes in BMD. So BMD monitoring is usually recommended 1 to 2 years after initiating therapy, whereas bone turnover markers, we can do it even prior to that. Like within 3 months itself, we can do it to see the response. So using the degree of change rather than the absolute value is more reasonable. So a baseline bone turnover marker should be done, and then we look at serial parameters. And basically the bone turnover markers which are studied are the type 1 collagen C-telopeptide, the CTX, and then serum procollagen type 1 N-propeptide, P1NP. They are markers of bone resorption. That is, CTX is for bone resorption, and the P1NP is for bone formation. These are recommended by the International Osteoporosis Committee. So for patients on anti-resorptive agents, we basically look at CTX. And patients on anabolic agents, we basically look at P1NP. And the measurements are usually done at, say, 1 to 3 months, usually at 3 months, then 6 months, and then 12 months. And we are actually looking at the change from the baseline. So for CTX, a decrease by at least 30% or a decrease by at least numerically 100 nanogram per liter from the pre-treatment value is what we are looking at. CTX should be taken in a fasting sample. P1NP, a threshold of more than 20% or at least an increase of more than 10 microgram per liter from baseline is considered to be significant. The above cutoffs, however, do not apply for combination and sequential therapies. They can be used more when these agents are used alone. So bone turnover markers are basically for treatment monitoring. Diagnostic value is not that much. Basically for treatment monitoring, we are using it. CTX and P1NP are the options which are available. Then we have the trabecular bone score. It is emerging as a new modality, which is complementary to the BMD. It is actually an analytical tool that performs novel gray level texture measurements on the lumbar spine DEXA images, and thereby captures the information relating to the trabecular microarchitecture. And low TBS has been consistently associated with an increase in both prevalent and incident fractures, and that is partly independent of both clinical risk factors and aerial BMD at spine and femur. And it is actually a software option for densitometer. So if we have the adequate appropriate software for that, it can be done in most of the DEXA machines that we are doing now. But because there are several validation issues, it is still not that much popular, not used in several centers. But there have been some papers from India also regarding TBS. One is from Chandigarh. They have done a normative data in population, normal population in Chandigarh. They have done the normal TBS scoring of that population. And in, I think from Vellore also, there was a paper in which they looked at the effect of zoledronic acid and the effect on changes in TBS, and patients who are given TBS, patients who are given zoledronic acid for osteoporotic fracture, they didn't have any further decline in the trabecular bone score. So these are two main papers which are available from India as of now. It has been found to have a very good predictive value for a 10-year probability of major osteoporotic fracture. Independent of the BMD score, it has a independent predictive value. But we are still awaiting its widespread use, basically in the initial stages, but promising data is available regarding its usage in fracture prediction. And in FRAX score, about which I will be discussing, or in FRAX score also TBS has been incorporated. A pan-India reference for TBS is underway, but therapeutic guidelines and thresholds cannot be currently based on TBS. We are awaiting the new data, and most probably some changes in the next few years we can expect. Then the most important aspect will be the screening tools. A large number of screening tools are available. Of these, FRAX is the most extensively studied one, because these screening tools, they basically take into account a large number of risk factors also. It is not, as we discussed previously, it's not just the T-score alone which is important. Several other risk factors are taken into account. So FRAX was first released in 2008. It is available for around 67 countries as of now, covering around 80% of the world population. And it has been externally validated in independent cohorts. It calculates an individual's fracture risk based on age, BMI, and a number of other well-validated risk factors. And also we can incorporate the femoral nerve BMD as well as TBS, but these are optional, and then it can enhance the fracture risk prediction. But even without these also, we can look at the fracture risk of a patient. And this is mainly for guidance purpose. The therapeutic decision should be made by the clinician after taking into account all the factors. So this is the FRAX tool. Country specific is there. So this is for India. I just went to the site and did this calculation, putting as a 70-year-old female with the height and weight, and then various risk factors they are asking, and I put it, actually in this I put no for everything. And finally, the risk has come up as for hip fracture 2.9 and major osteoporotic fracture 9.1. And we can even put T-score also, and even TBS score also can be put, and again the risk score can be modified based on that. So this is a tool, and which is very well used now. Most of the recent studies are using this for fracture probability assessment, and most of the guidelines are based on the FRAX assessment now. So FRAX is a computer-based algorithm that calculates the 10-year probability of a major fracture. Major fracture would be hip, spine, humerus, or wrist fracture, as well as of 10-year probability of hip fracture also. And the various factors are taken into account, and depending on that, the risk is given. And based on this risk, most of the guidelines are now evolving. So again, FRAX also has some limitations. There is no account for the dose responses. Like if there is a past history fracture, if there are 2 fractures, more risk is there. But there is no such dose response in this, where they don't take into account 1 or 2 or 3 prior fractures, or the amount of alcohol, amount of smoking. All these are not taken into account. The glucocorticoid dosage are not taken into account. Also, some amount of discrepancy can occur if you put the spine score instead of the femoral neck score. Even up to 10% of change in the fracture risk has been described if there is for every unit change of the T-score discordance. So all these are important factors in the FRAX assessment. But still, in spite of this, it is one of the very most commonly used ones, and very good fracture prediction data is available with FRAX score. And these are some of the correction factors based on the things that I have discussed previously. For various parameters, they have given some correction factors. These are some of the articles in which these correction factors are given. And for the steroid dose itself, they are given corrections like this. Like if steroid dose is low, you can even correct the whatever risk the FRAX gives, you can multiply it by 0.65. Medium dosage, no adjustment. high dosage like more than 7.5 can multiply the risk by 1.2. So these are there are several articles in which for the various factors, the corrections of fracture estimate can be done. Most importantly for the glucocorticoid dosage. So those are the other measures. So in addition to DEXA, we have bone turnover markers, which is basically for treatment monitoring. Vertebral fracture assessment can be done to find out asymptomatic vertebral fractures, and most importantly, prediction tools like FRAX score is there. So a general approach to risk assessment begins with the assessment of the fracture probability and the categorization of the fracture risk. And nowadays, actually, a patient at high risk can be considered for treatment without BMD also. For example, many guidelines in Europe, they recommend treatment even in the absence of BMD. If a patient has a past history of fragility fracture, they straight away put the patient as at high risk and they can be taken up for treatment. And in patients with a very low risk, they actually need not go BMD testing also. So in between these two come the intermediate category. Those are the patients who will actually require further assessment. So patients with very high risk, like a recent fragility fracture, treat as osteoporosis. Patient without any risk factors, without history of fracture, they come in the low category. You can do a categorization and then decide whether to go for further evaluation or not. But the intermediate category, such patients would require further evaluation. That is what is evolving in several of the recent guidelines. So ISBMR, the Indian Society of Bone and Mineral Research, they have given very recent guidelines for initiating anti-osteoporotic treatment. That is a recent vertebral fracture or non-vertebral fracture, and individuals more than 50 years of age with a T-score less than minus 2.5 at femoral neck or total hip or lumbar spine. And then based on the FRAX score, they have given the risk as more than 3.5 for hip fracture or more than 10.5 for general osteoporotic fracture. These values are different. In general, it is 3% and 20%. If you look at the US recommendations, most of the recommendations, they put it as 3 and 20%. But for India, based on the limited data available from India, ISBMR guidelines take it as 3.5 for hip fracture and 10.5 for major osteoporotic fracture. And for diabetic also, they have put the guidelines telling that in diabetic patients, the intervention threshold should be increased to T-score less than -2 and not -2.5. So these are the ISBMR guidelines. So basically, ISBMR guidelines, just like the US guidelines, they give a fixed threshold, like the values given are -3.5 and the values given are 3.5 for hip fracture and 10.5 for general osteoporotic fracture. But recently, there have been some changes in the European guidelines. A very recent European guideline, they actually give that it should not be a fixed threshold. We should assess the various thresholds. They have given these threshold, that is the intervention threshold. So for any patient, if the patient merits treatment, that is intervention threshold, and patients require further evaluation, that is the assessment threshold. So there is a lower assessment threshold and an upper assessment threshold. Upper assessment threshold means that above that, there is no need to go for BMD, treatment can be initiated. Lower assessment threshold means that the risk is very low, again, BMD is not required. So in between these two comes the patients who require further evaluation. And they are given these values, and I will come to that. So these are basically the various thresholds given. So on the left side, you can see that the red zone is above the assessment threshold, the upper assessment threshold. That means they are patients at very high risk. They do not undergo BMD. They can be straight away started on anti-osteoporotic treatment. Whereas patients in the green zone, they are patients at very low risk. They did not undergo further evaluation. They need to do general measures like calcium vitamin D supplementation, prevention of falls, all those things. Patients who come in the intermediate category, that is the orange zone, they should undergo further evaluation with BMD. And then after BMD, they will fall above the intervention threshold. That is the line going in between, within the orange zone, that is the intervention threshold. Intervention threshold means the threshold above which treatment should be started. So initially, the patients will fall in the orange category, and after BMD, they might fall in the line, they might fall above the intervention threshold line, or they might fall below the intervention threshold line. If they fall below intervention threshold line, they fall under low risk, they need not undergo any further treatment. Whereas if they are falling above the intervention threshold, they also should undergo treatment. This is what is recommended in the latest European guidelines. So they have incorporated FRAX score along with that BMD scoring, so that everything can be taken together, and then we can decide on treating the patient further. And the intervention thresholds are given like this. For various ages, they are given the risk, and that is taken as the upper assessment threshold, lower assessment threshold, and the intervention threshold. For example, if a 70-year-old female comes and we do the FRAX assessment, and the patient's score comes as a 33, it is above the upper assessment threshold. So they can be straight away started on treatment. We need not go for the DEXA scanning. Whereas if the patient's score comes as a 8 or 9% only, it is below the lower assessment threshold, we need not do further evaluation. But if it comes between 12 and 26, we have to do DEXA. And after the DEXA, the patient will fall under either of these categories. And if the patient falls above the intervention threshold, which is given here, that is above 22, we have to treat that patient. That is what is evolving. So this is from the European guidelines. So depending on the BMD, we have to further categorize the patient after the baseline assessment. That is what is coming up in the European guidelines. So I'll just summarize what I told once. If they fall in the red category, that is above the upper assessment threshold, they have to be started on treatment straight away. If they fall in the green category, that is below the assessment threshold, they are considered low risk. But if they fall in the orange category initially, we have to calculate based on the BMD. And after the BMD calculation, if they still fall below the intervention threshold, they need not be started on treatment. If they fall above the intervention threshold, they should be started on treatment. This is the way in which the recommendations are evolving. But this is from the European guidelines only. The other guidelines have not changed in this way. The US guidelines still give rigid values like 20% and 3%. The Indian guidelines also give values like this. So basically, the European guidelines have evolved like this. Maybe in the future, we will have to wait and see. Maybe other guidelines also will change in this way. But as of now, the European guidelines have started showing some changes like this. The assessment and intervention thresholds are given, and the values can vary from country to country and from person to person. And depending on that, we have to decide. It is not a rigid value. Whereas for India, we have rigid values and fixed values are given. So this is the rationale of combining BMD to FRAX, because when we combine these two, there is more predictive risk for fracture risk. So the Indian scenario is that we don't have thresholds, because these thresholds are basically based on data from 5 European countries. But in India, we don't have such a threshold which is available. So at present, I think we'll have to go by the fixed threshold given by the ISBMR guidelines for India. And this is one study in which they looked at the effect on the risk assessment strategies, and it was found that screening a population can help in reducing the hip fracture incidence. I'm not going into much of the details because of the lack of time. And these are the guidelines which I have gone through for the preparation of this presentation. The European guidelines are there, ISBMR guidelines are there. All these are published very recently. The ISBMR guideline was published this year. And then Asian Pacific Consortium of Osteoporosis also there. And then one other position paper also is there about algorithm for the management of patients at low, high, and very high risk of osteoporotic fractures. So to conclude, BMD by DEXA is still the most objective tool to assess fracture risk. It is the most well-studied variable in terms of evaluation and treatment of osteoporosis, but it has several limitations which we have discussed previously. A history of recent federative fracture by itself will make the patient a candidate for anti-osteoporotic treatment. Whereas other patients, we will have to do an assessment by combining the DEXA score along with the FRAX score. But this type of combination assessment is basically evolving in the European guidelines. Whereas for India, we have fixed threshold based on the FRAX score or other risk factors like a vertebral fracture or depending on that, we have to decide. Otherwise, based on the FRAX score, the cutoffs are given, which are lower than the cutoffs which are given for US population. That is that is 3.5% for hip fracture and 10.5 for general osteoporotic fracture. Then there are other methods like a vertebral fracture assessment, which can be used for evaluation of osteoporosis, and bone turnover markers can be used for treatment monitoring along with the DEXA.